Good afternoon, and thank you for joining us today. My name is Emmy Betts, and I serve as the Deputy Director for the Injury and Violence Prevention Center here at the University of Colorado Anschutz Medical Campus. Today's presentation is part of our monthly Research to Practice webinar series, where we present topics in injury and violence prevention. Before I introduce today's speakers, I have a few logistics to go over. First, this session is being recorded, and we will send the video link to everyone who registered. You can also find past webinars online, and we'll put that link in the chat. Please put any questions you might have into the Q&A box. We've timed the presentations today such that we should have time at the end for a really interesting discussion. So please put questions in, and then we'll get to them at the end. And please also mark your calendars for our other upcoming webinars. Our last webinar of 2021 will be December 14th, also the second Tuesday of the month, and it will be focused on youth violence. And so now it gives me particular great pleasure today to introduce our speakers, both of whom I'm fortunate to work with closely. Our session today will focus on strengthening trauma care with pragmatic research approaches. How do we do that research to bedside or research to EMS, street side dissemination? So the Cape Colorado Combat, or C3, Global Trauma Network is supported by the CU Center for Combat Research, which is led by Dr. Vic Babarda. And the Center for Combat Research, which we'll hear more about today, collaborates with CU investigators and U.S. military researchers and agencies on a range of relevant trauma and acute care topics to solve the U.S. military's toughest clinical challenges with practical solutions. Today, we'll hear about the Combat Center, but then more specifically, the amazing work going on with the C3 Global Trauma Research Network led by Dr. Mould-Millman. So our first speaker today will be Dr. Vic Babarda, who's a professor of emergency medicine and a senior physician scientist with extensive military leadership. He's the founding director of the CU Combat Center. He's a tenured professor, and he's vice chair for strategy and growth in the Department of Emergency Medicine. He's also a colonel in the U.S. Air Force Reserve in the Office of the Chief Scientist. Dr. Babarda's work has really shaped military and civilian pre-hospital and emergency trauma care, along with national policy. He's been continuously federally funded for 20 years to help solve the toughest clinical challenges for civilian and military care. Following Dr. Babarda will be Dr. Nicolfi Mould-Millman, who is the principal investigator and lead of the C3 Global Trauma Research Network. Dr. Mould-Millman is a federally funded emergency medicine physician investigator who has expertise in global emergency medicine and pre-hospital care systems. He's currently an associate professor at the CU Department of Emergency Medicine and also has an appointment in global health at the Colorado School of Public Health. Following his emergency medicine residency, Dr. Mould-Millman completed a dual fellowship in both EMS, emergency medical services, and global health at Emory University. He actively works in resource-constrained settings in sub-Saharan Africa, including Ghana, Kenya, South Africa, and Zimbabwe, where he collaborates closely with ministries of health, academic institutions, and government EMS agencies. His research is funded both by U.S. federal agencies and non-federal foundations. And his work has three focus areas: optimizing performance of out-of-hospital trauma care systems, pragmatic delivery of pre-hospital education, and improving pre-hospital trauma outcomes. And so we are really excited to welcome both of our speakers here today. And now I'm going to turn it over to Dr. Mould-Millman and Dr. Babarda. Thank you.
Great, thank you. Okay. Thank you, Dr. Mould-Millman. I'm going first. Perfect. So Vic Babarda, good to meet everybody here today. As Dr. Betts said, I founded and directed the Center for Combat Research across the CU campus at Anschutz, and which we focus on solving the DoD's toughest clinical challenges. The vice chair of strategy and growth here in the Department of Emergency Medicine, and also a tenured professor, and was active duty 14 years, and then several combat deployments, and now reserved with the Air Force, with the Office of the Chief Scientist, working closely with new policy and programs around combat casualty care, the folks here at CU. So I'll talk a little bit about the Combat Center, and it frames the work a little bit that Dr. Mould-Millman will speak on, specifically the project, pretty large project that he's been leading the last couple of years and the future years. And then we'll transition to him, and I'll kind of link the two back together a little bit at the end, how the military and civilians collaboration works scientifically, from an injury prevention standpoint, as well as how those entities work together, as an example being the Combat Center. Next slide. So as I talked a little bit about the center itself, we're here, that's our vision I mentioned. And our mission is to create breakthroughs in the care of combat-related injury and illness through innovation research, and we call advanced development, which means getting products through the FDA, devices approved with a military and civilian collaboration. Those solutions actually work quite well for our pre-hospital medics in Colorado and communities nearby, austere wilderness medicine too, as well as we'll talk a little bit about space environment, which CU is heavily invested in. The areas that we kind of focus on are where the DoD is going to. So some psychological health needs, prolonged care needs, which is Dr. Mould-Millman's work, late evacuation and trauma. I'll give you some examples in this as well. Next slide. So the center is based on campus. It's grown. It's only 3 years old, but it's grown hyperbolically in the last 3 years. We initially started sort of focusing on the departments of anesthesiology, surgery, and emergency medicine, and we've expanded now to involve the dean of the School of Medicine, actually campus-wide. So the other schools and colleges on campus as well. So primarily focused on acute care. And I'll lay out some of those topics, but acute care and injury prevention, as well as injury treatment, interpersonal violence, and traumatic brain injury and mental health as well. And across the scope, from basic science, the translational research, clinical trials, and post-marketing surveillance, where again, we call advanced development. Next slide. Some of the work we do is very tied to the military specifically. So what they need in those tents, the example there, for those specific blast injuries, and some a bit more cross-sectional to other environments, like civilian environments, civilian medics, and other agencies as well. So we focus on this military-civilian collaboration. So in this case, whether it's NASA, whether it's DoD, whether it's BARDA, whether it's NIH or NSF, all those things I mentioned, we've been funded through and to. We actually work in an innovative space as well. So we apply technology innovation to our solutions as well, both with C Innovations, with the Center for Health AI, Center for Bioengineering, and on unique, novel clinical trial platforms as well, based out of CU, to get those solutions delivered quickly for the DoD through the center as a facilitator. Next slide. Now, we work with different investigators on campus, both military and civilian. So we have this bi-directional relationship. We work with a lot of folks here on campus, work with the industry as well. But a lot of folks that we work with are new to DoD or non-NIH funding. They've been funded by foundations or NIH. So we work with them to say, okay, your particular topic, whether it's wound healing, whether it's mental health, whether it's injury prevention, whether it's interpersonal violence, how does that relate to the military? And is there a space for that, for them to fund? Is it a high priority? So we work with these 10 areas. The first ones in black, the first 5 are the fundamental science piece. So military relevance, military research office engagement, which office should you be applying to? Is it DARPA? Is it Special Operations Command, like Dr. Mould-Millman? Is it Navy, Air Force, Army? Is it Space Force? Where is it? And then do we need to have a military team around you that really accentuates and targets your particular research for the military audience? So co-investigators, collaborators, shared labs, those types of things. And then do we also need to have a military treatment facility or military hospital or clinical site that need to be engaged in this clinical trial or research that you're doing? And then of course, a pre-award, which is a lot different than the NIH approach. Then we kind of go through and help with industry relationships. If there's a partner there, how do you get something the DoD sees getting through IP and FDA and patent application support on campus and with the DoD, IRB, these second level approvals with the HARPO or CUROS, which are acronyms they use, and then any contracts and agreements as well. So on that whole transition plan from soup to nuts is what we help investigators to get funded, and when they're funded, they get through that process and sustain those programs over time, either with their NIH portfolio or specifically for their DoD portfolio or BARDA portfolio if they choose to develop that as well. Next slide. And we do have this bidirectional, so both intramural, so we actually work across the campus with, that's Memorial down south, so with our hospitals UC Health system, so North UC Health, South UC Health, a lot in Colorado Springs, there's a lot of military prevalence there, and a heavy investment from UC Health and CU there. But also on the right are our military collaborators, so active duty, Brooke Army Medical Center, the Institute of Surgical Research would come example. So sometimes they'll be lead and we'll be a co-investigator, or we'll lead the trial and they'll be a site for us, or we'll have the concept idea and work with their units at Buckley or the Academy or at Fort Carson or at Walter Reed or wherever it's at. And so it's a nice relationship and a benefit to them and to us to solve those problems for those medics and soldiers, sailors, airmen, and Marines. Next slide. That's it. And that's sort of the Combat Center. We're available. We work with a lot of folks. We have combatresearch.org. Well, again, we'll wrap at the end. I'll talk more about how Dr. Mould-Millman's project specifically benefits civilian communities, but also the military. So, Dr. Mould-Millman.
Yeah, thanks, Vic. Thanks, Emmy, for the intro, and thank you for to the leaders of the center for the kind invitation to share a little bit about our work with you. So what I'd like to do over the next half hour or so is to use an example of a DoD-funded global health trauma project in South Africa as a case study to illustrate perhaps two big points. One is how research can be done in a bit more of a pragmatic way that is embedded within host organizations to help strengthen the organizations along the way to yield a result that is a bit more impactful than just the research itself. And then secondly, how findings from global trauma research can, in a small way, benefit a myriad of populations, in this case, South Africans, perhaps folks in rural US, and military populations. Yeah, please feel free to jump in with any questions. I have no conflicts. This work is funded by the DoD, the NIH, and the Emergency Medicine Foundation. And as you all know, these sorts of programs don't happen in isolation. And I'm very indebted to and grateful for a large group of very committed and exceptional people, both here at the University of Colorado, in the Western Cape of South Africa, at the University of Cape Town, and also in the US Army and the Air Force for their support of this work. And of course, the project it's important to, I think, contextualize the project I'm about to describe because it's built in the backbone and on the infrastructure of a larger research network and a collaboration that's existed for almost a decade now between myself, our department, the university, and several entities and organizations in the Western Cape of South Africa, including the Western Cape Department of Health and the University of Cape Town and Stellenbosch University. And so this is just one of several projects I'm going to tell you about. So the first question is, why trauma? And I think I'm preaching to the choir when I say because injury is a leading global cause of death and disability. If you're between 5 and 40, it is the leading cause of death. And it doesn't matter if you are in Africa and rural US or military, the same applies. However, in Africa and many other low and middle income countries across the world, populations experience a disproportionate share, which is 90% of the global burden of disease. So clearly more work needs to be done in these settings to improve global trauma outcomes. In rural US, for example, if you are injured and you have the same injury profile as somebody who lives in an urban area, you are twice as likely to die if you live in a rural location in the US. In the military, hemorrhagic shock, for example, is a leading cause or the leading cause of preventable mortality amongst military and combat wounded. So injury, I think, transcends populations, beyond income settings and whether you're in this civilian or military sector. And to make things worse, even though injuries and disability across the world is actually improving in most parts of the world, shown in green and the light shades in this figure, what we actually see is if we focus in on road injury trends for disability-adjusted life years between 1990 and 2013, we actually see that West Africa and Southern Africa are actually worsening. They're going the opposite direction. And if we look at intentional injuries, the same trend holds through, and Southern Africa pops out even more and has some of the largest disparities in outcomes globally. And again, this is just disability. And if I pulled up a slide of mortality, the same would hold true. So when are people actually dying from trauma? Well, historically, there was a trimodal distribution of death in which there was an early or an immediate peak within the first few minutes to an hour. And then within several hours later, a second peak. And then about a week or two later, there was a third peak. And due to advances with hospital care, what we've actually seen is recent studies have shown that the latter peaks, the early and late peak, have actually sort of died down. And there's an even larger peak that occurs within the first few hours of injuries where the predominance of death occurs. And so this begs the question, what can we do as emergency care providers, as a health system, to bring critical resources closer to the point of injury to help deliver these time-saving interventions in an earlier fashion to help avert this large peak of deaths? And this holds true in both lower-income countries and higher-income countries. So emergency medical services are exactly positioned and designed to do just this. So these are highly cost-effective public health interventions, even in low and middle-income countries, and this has been demonstrated in multiple studies. And in general, they can reduce deaths from emergency conditions by up to 50%. Yet, EMS services are a neglected area of research according to the World Health Organization. So what does EMS do? I think in trauma, there's three specific things. There's early care at the point of injury, for example, controlling hemorrhage, or reestablishing an airway so you don't die or asphyxiate to death. Triaging patients, which is determining where would be the best location to send the patient to. And if you're critically injured, bypassing a small hospital and going further to a trauma center. And of course, providing rapid transport. There's some injuries where there's nothing to do but rush a patient to a trauma surgeon. So individually, evidence exists that demonstrates that there are specific health interventions that are highly efficacious. What we don't know is how these perform altogether. And secondly, how we can introduce these into care in an effective way. And further, in resource-constrained settings, what are the specific approaches that have to be considered? So what I'm going to do now is zoom into South Africa. And you recall from those earlier global maps that Southern Africa is a peak. Well, within South Africa, the Western Cape province, which is on the western side of South Africa, shown here with Cape Town, sort of here. So South Africa is a middle-income country, and it's an ideal setting for doing trauma research for a myriad of reasons. Well, there's an incredibly high post-injury mortality rate, up to 6 or 8 times the global average if you are a victim of interpersonal violence. It has some incredibly high wealth and income inequalities. So it has the highest Gini index of any country in the world. And of course, there's this legacy of post-apartheid institutions and so forth. So for many reasons, the Western Cape of South Africa has an exceptionally high trauma burden of disease, both death and disability. As you can imagine, the trauma system itself is incredibly strained, is very pro-education, which is great, and has both high and low income country features, which make the findings, I think, quite generalizable. And they have a very standard, sort of an internationally standard EMS system, which I'll talk about in a bit. So this is an example of a township. This is a dense informal settlement where a large majority of trauma emerges as a result of unemployment, drugs, there's gang warfare, a lot of interpersonal violence. And unfortunately, scenes like this are not uncommon in both the Western Cape and across South Africa, begging the need for more effective health interventions and simple interventions that can actually yield some effective outcomes. This is an example of the Western Cape EMS system. It's a government-funded EMS system that has about 2,000 personnel scattered over an area the size of half of Colorado. So it's quite geographically large for a singular EMS system. It's also one of the best in Africa, and I think for all these reasons makes it a great place for us to do pre-hospital trauma research. So I'm going to take you to the genesis of the project. So around 2016, as a result of some ongoing research we were doing in the Western Cape, we realized that about 7.5% of EMS trauma patients were in hemorrhagic shock. This is actually quite a high proportion, but what was even more startling was that about 60 to 70% of these patients were receiving almost zero pre-hospital interventions, except for transport, which was quite alarming. At the same time, in high-income settings, bundles of care in hospitals were all the rage, bundles of sepsis care, of cardiac arrest. And studies have proven that these were efficacious ways to introduce interventions as a group to practice settings and for practitioners to take them up and use them consistently. So I thought, well, why not try a bundle of shock care for EMS? Hadn't been done before, so that was an idea. And then as I was grappling with that, I was wondering, well, how exactly would we introduce this bundle to individual EMS providers with the additional constraints of resource limitations? As a learner myself and as an adult professional learner, I think I've been quite frustrated by, traditional classroom-based education. Other studies have demonstrated that for EMS professionals, that critical knowledge and skills and life-saving interventions decay after about 4 to 6 months. And frankly, a lot of EMS education was not friendly for the adult learner. And I borrowed an idea from the Helping Babies Breathe group, which was essentially doing little bits of education in a clinical practice setting, in what they call a low-dose, high-frequency manner, in which little bits of education are introduced for about 15 minutes and repeated weekly or bi-weekly, as a more effective methodology to teach and train, as opposed to sitting in a classroom or going to a skills lab for 1 or 2 days, once or twice a year. So with those two ideas in mind, I approached my collaborators in the Western Cape of South Africa, the EMS system specifically. And long story short, we engaged in about a 1.5-year long process of discovery, where I really got to understand what their pains and gains were around trauma care, EMS education, and so forth. The organization sort of bought into the idea and developed a HEAT team, and I'll tell you what this is in a second. But that paved the way for us to validate and develop some of our instruments we would use for our subsequent research, to conduct an initial feasibility study to demonstrate that actually our intervention and a novel approach would be acceptable and feasible within their system. And then what I'm going to tell you about in the rest of this presentation is about the Pragmatic trial that we undertook from 2018 to the end of 2019. So the HEAT team is a multidisciplinary group of leaders from within the system, within the EMS system, that come from many different facets, with all of which touch on some aspects of trauma care or education. And so this team was essentially the key team which the research team would work with to implement the intervention and conduct our assessments. And I think this is a critical part of the success of the entire program. So a little bit about the background. So the intervention was a bundle of EMS traumatic shock care termed EMS True Shock. The implementation strategy we sought to assess was termed HEAT, which is a high efficiency EMS training program. And our logic model was as follows. If we could effectively implement True Shock using HEAT, in theory, we would improve providers' knowledge, attitudes, and skills, which would then improve their quality of trauma care, which would then improve patient shock indices, which is a physiologic measure of how a patient is doing with shock from the point of injury until arrival at a hospital. And so we linked some of our scientific aims to each of these intermediaries. The EMS organization made some very firm commitments to the program, which allowed us to co-develop the intervention. We embedded the HEAT leadership team and the program deep into the organization. We co-branded it, we co-owned it, and I think the research team was equally as invested as the HEAT team, which was phenomenal. We even went so far as to write out 5 to 10 year sustainability plans before we even implemented the program, as their commitment and testament to the program. Even though our clinical intervention, EMS True Shock, has several components of recognition and management, what I'm going to focus on for the rest of this presentation is really just the core aspect, was a simplified bundle of care. Individually, each of these 5 elements has data to say that it is effective. However, no data exists to say that if delivered all together, that the sum was greater than the individual components. So our expectation, as most bundles of care go, is that all of these would be performed on 100% of traumatic shock patients. In terms of the implementation strategy, so the HEAT program, what we did is we took our true shock, the traumatic shock care bundle content, and we chopped it up into little educational objectives oriented around knowledge, attitudes, and skills. And this is just an example of what one of the 5 modules looks like. And the way this module is implemented in clinical practice is that we have a trained paramedic who we call facilitators of our program. And these are just peers to their colleagues, 2 EMTs over here. And the paramedic would essentially take their colleagues in 15 minutes in the back of the ambulance at the start of a clinical shift and walk them through the materials in a very structured way, but also in a relaxed conversational way. They would have an opportunity to have discussions and practice some clinical skills, and then complete a quick evaluation for 2-3 minutes. And in under 20 minutes, the ambulance would be on its way to respond to calls. So our research questions were as followed. We wanted to assess the implementation effectiveness of the program using the REAIM framework. We wanted to assess educational outcomes, which are actually a component of the overall implementation effectiveness, but we wanted to tease this aside on its own. For this presentation, I'm just going to give you a very summarized high-level overview of our educational outcomes. There is a ton of literature and findings we have on these, but I won't be able to share all those. And then as a secondary outcome, or a second outcome, we were also keen to assess clinical effectiveness measured by the change in shock index. And a shock index is a heart rate divided by a systolic pressure. And we assess this for each patient at the point of injury and upon arrival at the hospital. So the overall research design was really a pragmatic hybrid type 2 quasi-experimental trial. And I'll explain all of these. So a hybrid type 2 trial is an implementation science design, which allows an equal focus on the implementation outcomes, as well as the clinical level outcomes. Quasi-experimental because we could not randomize the intervention at the level of the individual provider. There would be too much cross-contamination. We decided to use a mixed methods approach because we wanted some rich qualitative data to help us explain some of our quantitative findings. And of course, we did this in the Western Cape EMS system. We implemented our intervention between August and November of 2018, and we assessed clinical data for 13 months pre and 13 months post-intervention. Participants were twofold: all EMS providers at 2 stations, an intervention site and a control site, and any EMS trauma patients they took care of who were in shock. So we were quite liberal with our inclusion and exclusion criteria. In terms of site selection, we tried to match 2 EMS bases based on the population they serve, the number of ambulances and providers they have, and the acuity of trauma patients they take care of. So whatever outcomes we assessed at one site, we concurrently assess them at the other site. We use the REAIM framework, which is perhaps one of the oldest known implementation science frameworks used for planning and evaluation. We chose REAIM, frankly, because of its simplicity, both for research planning, but also to allow us to communicate easily with our stakeholders. I would encourage all of you to look at this at some point. So we collected data using training rosters, feedback forums, exit surveys, participant interviews, stakeholder interviews, and we organized all of these, both quantitative and qualitative, into the REAIM framework, and I'll show you the results later. In terms of educational processes, we collected data from standardized assessments, which were broken up into knowledge, attitudes, and skills. We did this pre-post month 4 and month 12, and all the educational data was actually collected by the HEAT team. And these are examples of what the custom-built paper-based forms look like. They were deliberately designed to be very simple to use and collect. And our idea was that an entire assessment should be able to be completed in 15 minutes, which it was. In terms of patient outcomes, we had to design custom data collection instruments, which we housed on REDCap. And we trained 3 Western Cape paramedics to review and essentially abstract the data and enter them into REDCap. And we actually had validated the instrument that we used for the study. Analytically, for our clinical outcomes, we use the difference in difference analysis, which allows us to essentially to compare changes in the outcome at the intervention site compared to the concurrent control arm, both in the pre and post implementation phase. And of course, we had all the relevant ethics from South Africa, the U.S., the DoD, including data share agreements. We did collect informed consent from the EMS providers, and we had a waiver of informed consent for our trauma patients. So what did we find? We certainly did a lot. What did we find? So at baseline, there were really no differences in baseline characteristics in both our implementation versus our control site. When we look at EMS providers, we had about 200 providers who participated, roughly 100 at each site, similar age, sex, years of experience. We did have more basic life support providers at our control site than our intervention site, but aside from that, they were fairly well matched. Similar with the patients, these providers took care of a total of about 770 traumatic shock patients, also with no baseline systemic differences at the intervention versus the control site. I think what's interesting and to point out is that 53% of patients actually had penetrating injury. As a comparison, in the US, that number is about 10 to 15%. And these patients are at severe risk for hemorrhagic shock. We also saw about 42% of these patients in severe shock. Also, I think it's maybe interesting to note that 770 patients from 2 sites in a 2-year time span is actually really impressive. It would take 2 US ambulance bases about 5 to 7 years to be able to enroll the same number of patients. So we have about 2 to 3-fold research efficiency from doing this work in a high trauma population. So what I'd like to do now is orient you to the results and implementation effectiveness oriented by each re-aim domain. So let's start with reach. So reach is defined as the proportion of eligible participants who ultimately participated in the program or received the intervention. And so you'll see here, we have about 70% of EMS providers, eligible providers, who actually completed our program. This may not sound like a lot until you consider that the usual EMS education programs in the Western Cape yields about 5% participation rate. So this kind of blew the traditional training program away from that sense. When we zoomed in on patients who received our TrueShock bundle, any component of the bundle, I'm sorry, this is actually, I think, 3 out of 5 components of the bundle, is roughly about 60% of patients. So on the right are qualitative data, which we collected to kind of try and explain some of the quantitative findings. And these are some of our key themes. So you'll see that the learners said the timing during shifts, the short sessions, was some of the key factors that enabled them to actually participate with fairly high attendance. And then for patients-wise, I was hoping this number would be higher. The providers did say that the bundled care really allowed them easy recall and application in the field. They thought it was a very simple approach to an otherwise complex algorithm of care. However, the BLS, the basic life support providers, did note that sometimes they didn't have the IVs and oxygen tubing they needed, to be able to implement this, 100% of the time. In terms of effectiveness, which is defined in this case as the educational outcomes, and we looked at learners who, for example, improved their knowledge in more than one element, improved skills in more than one area, and so forth. And we also factored in the composite evaluations. There are a few other metrics that I haven't included here. Overall, we saw the mean effectiveness around 87%. This is really excellent. And some of the feedback we got is that, from the providers, is that the fact that we use relevant cases that they see every day on the roads was really impactful and useful to them. They thought that the discussion format was excellent. And they loved that we had a peer lead their learning and not a traditional EMS educator. Additionally, they noted that being able to practice skills during each session was really useful for them. And the fact that they could use their own ambulance equipment and do this in the back of their ambulance was even created even more of an enriching educational environment. They also noted that discussions enriched, the whole experience. Some feedback was that they felt like they needed more time to have question and answer, and they felt sometimes a bit pressured to go back into service to respond to patients. But we expected that would happen. In terms of adoption, which is defined as the likelihood that the organization will adopt the program as is at its completion, we had an 87% sort of mean score. And I'll tell you that our stakeholders, the learners, the managers, the facilitators, I think unanimously sort of agreed that this was an excellent program and strategy for EMS and fit in really well with their operational environment and also their educational needs. And I think that's perhaps not surprising because we designed this program in tandem with the organization. And sorry, I'm just going to go back to that. One thing I'd like to point out, which we didn't quite expect, was that some of the feedback we got about why our program was especially beneficial to them was because it actually improved communication and rapport amongst the staff. Apparently, this was an issue pre-program. So in addition to gaining knowledge and skills, we got constant feedback that, oh, the crews are now talking more. We seem to have broken down some traditional barriers. And so that was an inadvertent but sort of pleasant consequence. Implementation fidelity is defined as how accurately the program was implemented as it was intended. And in this case, for example, completion was defined as participating in at least 4 out of 5 training sessions and not having more than 3 learners in any one group and so forth. And so we didn't do as well as we had hoped, 72% here, but a lot of credit was cited to the fact that the trainings are designed to start at the beginning of shift time, which forces many people to attend, and ultimately people enjoy it. So then it's this, it's this self-fulfilling sort of prophecy or cycle. We did note that EMS crews were sick or went on leave, and I think that really impacted some of the attendance. Yeah, so I won't go into any more details there, but overall, so when we average out all our domains, we yielded an overall effectiveness of around 78%, which is classified as high and was consistent with our initial feasibility study. So a few more slides. So in terms of educational effectiveness, just stepping back and doing a macro level assessment, we had overall about a 20% improvement in knowledge, 15 in skills, and about 10 in attitudes. So I should point out that prior studies in global health educational interventions usually yield a mean effectiveness size of anywhere from about 15 to 25%. However, knowledge in those studies decays at about 4 to 6 months. We actually found that we yielded a 20% improvement and knowledge was sustained at least 12 months post-training, and that was quite remarkable. Secondly, I should mention that 20% improvement in knowledge in our study corresponds to acquiring about 2 to 3 new pieces of knowledge that are actually critical, life-saving in a traumatic shock care. And so as an educator, as a clinician, I think this 20% is exceedingly clinically and educationally meaningful. Similarly, skills acquisition of 15% translates to about acquiring 1 to 2 new life-saving trauma skills. It's also very meaningful. Our self-efficacy assessment instrument, I think, was poorly sensitive and didn't really reflect the qualitative feedback we got, which is a lot of providers were leaving trainings, going into practice, and the next time we saw them saying, oh my goodness, I feel so much more confident in my abilities. I feel like I did all the right things when I got to the next trauma scene. And we heard that those testimonials countless times, by the dozen, each week sometimes. It was really remarkable. So last, clinical outcomes. Sadly, we did not measure the statistical difference we wanted. So on the vertical axis is the change in shock index, with a lower score actually being better improved shock. Blue is our intervention cohort, and then the dotted red line is the control group. And even though we see that at baseline, even the intervention seems to be performing a bit better, that effect was sort of sustained all throughout. But again, overall, across all time points, there was no statistical significant difference between both sides. However, in one pre-planned subgroup, specifically in patients who had severe shock, which was due to penetrating injury, and if those patients were treated by basic life support providers in the immediate post-training period, we actually noticed that there was a significant difference. But again, this is really one subgroup analysis, and we don't want to read too much in this. But I think this fits some of our pre-study notions and hypotheses, which were basic life support providers would stand to gain the most from this basic intervention, and patients in severe shock would also stand to gain the most. And I think this really fits clinically. So what were some of our research conclusions? Again, stepping back, that heat did have a high implementation effectiveness. Heat seems to be a really effective educational strategy, again, compared to traditional education. Unfortunately, the true shock intervention didn't have a significant clinical benefit, but there's a possible benefit for some of the most critically injured patients. If we take an even further step back and consider what some of the meta findings and experiences were, we really think the EMS organization learned some new skills, specifically a novel training approach, which they're running with, and I'll show you that in a second, how to conduct contemporary assessment methodologies, how to develop tools and instruments. And we provided them a little bit of a model for how they can bring their multidisciplinary experts together to collaborate on projects. Apparently, this had never been done together, to pull together all the different units into one project. And I do think the embeddedness of the research within the EMS organization helped achieve many things. One, there was more organizational ownership, which resulted in less reliance on the research team. It made my job easier, to be honest. There was much, I feel like the implementation was much stronger than if the research team had tried to do it on our own. There was so much buy-in at so many different levels. It was really refreshing. And there was this stronger tailoring of the intervention and the implementation for the organization. And of course, there was a sustainability plan built, which is something that usually research studies don't do. And to be honest, I realized the value of adding qualitative to traditional quantitative studies. To be honest, the qualitative findings felt really more impactful than the quantitative. And I'll tell you, when we're presenting these data back to the South African stakeholders, their eyebrows would raise at the qualitative findings much more than the quantitative. And I think those testimonials really, I think really resonated with them and brought the program to life. So it doesn't end here. And I think perhaps the next bit is perhaps maybe even more interesting. So late in 2019, we were wrapping up our heat and true shock program. And as we were doing that, of course, the global pandemic struck. And very quickly, the Western Cape EMS system was overwhelmed by the need to have to train over 2,000 EMS providers scattered over an incredibly large geographic area with really bare-bone resources. And I think the HEAT team scrambled together, disassembled the HEAT program, removed the true shock content, replaced it with COVID-specific training, and repackaged and reformulated it. And within 3 months, they were able to deploy the rearmed HEAT program across their entire province. And I think within 4 months, they were able to reach and train almost every single EMS provider in their province. And the feedback I got from them is this would have been otherwise impossible to do in under a year with their educational traditional modalities. And I think this was extremely affirming and heartwarming, to be honest, as a researcher and a global health person. And the HEAT team was so proud of their achievements, they actually went on to present their story at the African Conference in Emergency Medicine to share this program in the hopes that other EMS systems across Africa would be keen to sort of adopt the program and the training strategy. So bringing this back home, so what are some of the implications for rural US and other lower middle income country EMS systems? So first, HEAT on-site training is effective and it's really enjoyable for these adult learners, and it's potentially really cost-effective, even though we haven't formally done a cost-effective analysis yet. It seems promising model for highly resource-constrained systems, and we've proven that actually HEAT can be adapted for other training content beyond trauma and even beyond COVID. Bundles of care do seem feasible to implement in resource-constrained settings, with a caveat being that the health system must ensure that there is a minimum amount of equipment that is consistently available so providers can implement these interventions. And at the patient level, of course, while there was some signal towards a clinical benefit amongst the most critically injured, we do think more testing is needed. And so what I'd like to do now is ask Dr. Babarda to perhaps comment on what the US military could potentially gain from this program. And then we'll open it up to some question and answer from the audience.
Great. Thanks, Dr. Mould-Millman, and great work. So, here's a good example, the Kofi, of the work that this military civilian in this case, and international health can work together on as global health. So NCOVI's example of you can do all three at one time. The value of this for the DoD is pretty significant. So a lot of times we do research to try and change something in 15 years. The DoD value changes in a couple of years, and they have been very impressed with NCOVI's program he's developed for 4 years, and they made a very, very large investment. And the fact that they feel that NCOVI's work will transform combat medicine policy and investment for about 1.5 million service members over the next decade. So he's having a remarkable impact. These studies that he's generating, these publications generating, the work that he hasn't even talked about, this is more on the training side, is remarkable. And what happened is when we originally had this conversation with the center and NCOVI and the leaders in the DoD, is we found out that we had a hard time training our medics because some of the volume of the casualties had gone down in the war. But in NCOVI's environment, the medic training was similar. The medic skill set was similar. The recruitment of the medics, actually, even though it was civilian in South Africa in the military, was similar. The types of injuries they were seeing were similar. The type of procedures they needed to do were also similar. And in a specific case, the prolonged time from injury to definitive care was also similar. So they saw it as a perfect environment to partner with ethically with South Africa, the military, and in this case, with University of Colorado. And so the original piece was on the training side, and what they had done years ago is called hip pocket training. So a very simple version of what NCOVI just laid out for you, which is when they're in the field, they would pull out something out of their hip pocket and say, okay, say do a chest tube or crike, an intubation, a procedure, say transfuse blood. What NCOVI then is took that sort of old concept, modernized it, and said these high consequence, low frequency events, how can they work? And then added on this clinical outcome, which the DoD has never seen before. They have always talked about educational interventions, and how long do you retain it? But no one's actually taken the moment to say, not only how long do you retain it, but do you have a high enough population of events and patients to actually change practice? So they were quite impressed with this work, and this model is being adapted and used, especially on the special operations community. So those of you who don't know, that's where the Green Berets, the Rangers, the Navy SEALs, in their deployed settings, these high consequence, low frequency procedures, these bundles of trauma care into what they call the clinical practice guidelines, CPGs, is rolling this philosophy into those CPGs for practice and in their training. So when they're deployed and they're in Africa or they're in whatever country, Philippines, and still in the Southwest Asia, they may not be seeing a lot of casualties, but they can train quickly with high fidelity, and the data shows it actually works quite well. So the DoD has then followed on this with additional investment to say this model works for training. This casualty population is important for us to actually understand what happens with these folks who are 6, 12, 24, 46 hours, 48 hours from injury to definitive care, and continue to invest in Dr. Mould-Millman's work. But part of what we've done, we have a philosophy around how to make intervention changes called .MLPF. So it's doctrine, training, leadership, material, research, facilities. And the work that he's done is they have pulled it into their doctrine. So they're going to train and rewrite the books on how they train medics. The organizations are going to redo how they organize their training for deployment. So when they get this type of, their supervisors get this type of training, and also put those supplies in there for cricothyrotomies, for intubations, how they do that. And of course, the research goes along with it for their new policy on how to use this. So they've been very impacted by his work and the work that we're doing with South Africa to fund and support future studies as well. So.
Wonderful. Thank you both so much for what you are doing. I knew a little bit of it, but really fantastic to see the full spectrum of this project and think about how it's really shaping shaping care in both military and civilian settings around the world. So we do have a few minutes. If anyone in the audience has questions, please put it into the Q&A. I have two questions. I'll take moderator privilege to start. So first question, kind of a softball for Dr. Babarda, but often our audience are injury practitioners, researchers who may not have thought about military relevance before and may feel a little unsure of even kind of how to start or how to think about it. So is it fair to say that you'd encourage people to reach out if they may have projects or ideas that might be of relevance to military populations and reach out to the Combat Center?
Absolutely. Yeah, thanks, Dr. Betts, for that question. Dr. McKay is actually on the attendance now. He's our Dr. Jerome McKay. But you can go to combatresearch.org. We found that there's a lot, just like on the civilian side and the military side, there's a lot of questions that are unanswered. They don't have a good solution or a good team to go to. And you'll be surprised some of the work that you're working on is very, very relevant. And in the interest of an investigator, can be financially supported by the DoD, and aligns with an NIH portfolio or NSF portfolio, aligns with a state program you may have as well. And a lot of folks on campus who are experts in their field have actually been help the DoD solve those problems. It's not just about shot up, blown up, burned up chemical weapons. It's actually about mental health, resiliency. It's about training, education, all the interpersonal violence, pain, all those things of our EMS communities, our local communities, and the DoD are all the same. So happy to chat with you, and we can help talk with you about those. So thank you, Emmy.
Wonderful. And I'll also plant the seed for people who do various kinds of transportation work. I'm thinking about impairment when operating machinery and so forth, also certainly of relevance to communities.
And Dr. Flaherty, Dr. Flaherty is our Deputy Director. Brigadier General Flaherty is our Deputy Director of the Center as well, is on the call as well. She just put in a comment for folks. So.
Wonderful. Thank you for joining us. Next question for Nikofi. I'm curious if you just have any general comments about doing global health research in the middle of a pandemic. I think probably a lot of people are wondering, how did you even keep this up and running? It sounds like you were done with your main data collection before COVID hit, but what has the pandemic done to thinking about doing this kind of work on a global scale?
Yeah, no, it's, well, I think the need for sustainable programs, I think it's even more important no matter where you are in the world. So I think in that sense, that's, perhaps one contribution. But I think what you're getting at is for global health practitioners and researchers, how do we survive when you can't travel and the focus is all on COVID? Great question. I think, to be honest, the way I phrased this is COVID has been really a stress test to many things, but especially to global health programs. And I think what we've seen, and talking to my colleagues, across the U.S. who do global health, their experience has been, if you've done a good job pre-COVID embedding your program, within an organization, building capacity locally, if stakeholders really believe in the work you're doing, everybody realizes, COVID will, I don't want to say come and go, but other conditions still exist. Trauma is still the #1 health nuisance, in South Africa, even during COVID, so I think what we've seen in COVID is those programs that have really done an awesome job to think beyond just the research phase have really sort of thrived, So that way, when I wasn't able to go for a year, I knew we had people who had bought in and capacity was built and things could still function, in my absence, which is great. And that's exactly where you want your global health program to get to.
Mm-hmm. Thanks. I was thinking, in listening to both of you speak too, about how the importance of embedding this work in real partnerships for it to succeed, whether those are partnerships with military installations and military groups or overseas. That this is, this to me seems like a perfect example of how you can't just go and do something to study a group. It's really about how you make the work relevant and get buy-in from whatever population you're with, and not just buy-in, but really integrating them into the study design and how you're carrying it out, and thinking about how we can offer expertise, but at the end of the day, it needs to be solutions that work for the communities that you're working with.
Yeah, I think Nikofi's done a great job with that, really engaging, and that's in value, that specific skill, that, like you said, not just that they have buy-in, but they actually benefit from that community, especially in a community like he's working in. So they benefit, the sponsor benefits, of course, that research is published, whoever's reading that in the United States as well would benefit. So that's a pretty unique Venn diagram that he's got into that's been valued by several folks.
And I'll tell you in a very selfish way, now when I go back to the organization, I'm like, hey guys, you want to run another program? They're like, yeah, bring it on. Awesome. Because there's all this goodwill built as a result of the prior program, and so it's I don't know, it's this self-fulfilling, sort of cycle and prophecy where if you really give back and you try and put the organization first and see things through their lens, I think as a researcher, I think that only will benefit and strengthen your subsequent research programs. At least that's sort of been my experience. Yeah, I wouldn't call our program Emmy as perfect by any means, but yeah, it certainly was fine and complex.
Any tips, Nikofi, from, so you have built this amazing program, certainly in collaboration with others, but really this like meteoric rise in terms of what you've been doing. Tips to other researchers out there or practitioners, how do you build and manage something like this? I mean, I'm guessing you have good people working with you who are smart and organized and so forth, but any sort of closing thoughts for people who want to be you someday?
Not about me, but yes, I think this is built in collaboration with many others, and I think talent, finding good talent, and I've been fortunate to be able to really work with some talented people both here and overseas. But I think more importantly is actually finding a common vision, a common area that you can all galvanize around, and I think that fuels us and pushes us each day, to keep going and wanting to be better. And so for me, that was not just EMS, that's still big, that's vague, it was actually around how can we do a better job at training, and how can we take better care of our trauma patients? And everybody can, at least in my world, could sort of see the value and could galvanize behind that, including the military population, the South Africans, and so on. Yeah, so I think those would be, I guess, some high level advice. Beyond that, it's all about the nuances of your program and management and so forth. I was also lucky to come from a very heavy programmatic background. I think in EMS they teach you how to run a service, how you build programs, and I think I draw on that often as I design programs, perhaps more so than I think I bring perhaps too much of that aspect and less so of the research focus to a lot of my programs, because I do believe in the viability and the sustainability, and what can you give back soon? What can you build within an organization? So in a small way, maybe they're better off, because you were there, and so that's, anyway, that's a few thoughts. Yeah.
Yeah, thanks. I think that's great. Thinking about how we as researchers or professionals find our own niche based on our own background. And I think I love that idea of a shared vision with the people you're working with. Yes, we're almost out of time. I hope others will join us for our next webinar on December 14th. Any closing thoughts or anything you want to add from either of our speakers today? Oh, you're on mute.
Sorry, thank you for the work you guys are doing at the center. It's great work bringing so many different disparate groups together for this audience and for the center as well, for your center. It's great to be a part of it. So thank you for that. Good resource for campus. It's great work.
Yeah, I'd just like to echo that. I'm a fairly new member to the center, so thanks for the invitation. I look forward to learning from others and hearing your presentations in the near future.
Yeah, well, wonderful. That's certainly part of our vision, is how do we bring people together from these different areas and realize actually how much we can share. So thank you all for joining us. Thank you so much to our speakers for today. Be safe, and we will see you in December. Thank you.